Hi everyone, my name is Dr. Caroline Baker and I'm going to be presenting the first session in the International Aphasia Rehabilitation Conference 2020 segment. I'll just take you back a slide. Yeah. IARC 2020 is a biennial conference involving 200 to 300 aphasia researchers and speech-language pathologists from all over the world. And unfortunately, as Todd mentioned, it needed to be cancelled this year. It was to be held in Vancouver. On behalf of the IARC community, I would like to thank the committee chair, Dr. Tammy Howe, co-chairs Evan Sinden and Brent Page for their hard work and dedication. And we're all looking forward to when we can all meet again for the next IARC. In this IARC 2020 segment of the teach-in, there are going to be 4 presenters from 4 different countries. I'm in Australia. Katarina Hillary will follow me from the UK. Marie Kristen Hull will then be speaking from Canada, and Yuda Isaacson will end this segment of the teach-in from Denmark. So I'm a speech-language pathologist and postdoctoral research fellow with the Centre of Research Excellence in Aphasia Recovery and Rehabilitation at La Trobe University in Melbourne, Australia. And today I will present findings from my PhD, which I studied through the University of Queensland, and my research in my current postdoctoral role to implement psychological therapies for people with aphasia. So firstly, let's discuss mental health and the concept of mental health. Everyone has it. Everyone's experiences of mental health is different, particularly for people with aphasia and their families. And my PhD program of research described the many evidence practice gaps in translating psychological care to aphasia rehabilitation following stroke. From my talk today, I hope you can take away some information from 3 key areas as we move through the content. Firstly, talking about some solutions to these evidence practice gaps. We'll discuss how we can work together to provide psychological care, working together with people with aphasia, their family members, and members of the multidisciplinary team. We'll also cover some aphasia-friendly psychological interventions that we are investigating in our research at the Aphasia CRE. So mental health can be conceptualised on a continuum. In this figure, the x-axis here represents the various states of mental health, while the y-axis represents the percentage of the general population. The continuum of mental health has been described to encapsulate both mental illness and mental or psychological well-being. Mental well-being spans the continuum of states that range from languishing to flourishing levels of functioning. Most of the general population is represented here in a state of moderate mental health. Mental well-being is important for recovering to an optimal level of functioning after adversity or trauma, such as the life-changing circumstances of stroke and aphasia. We know that people with aphasia can experience the continuum of mental health from mental illness through to mental well-being. However, people with aphasia are at high risk of mental illness compared to the general population or stroke survivors with aphasia. So if we look at the most common mood problems in depression, We know that people with aphasia have double the rates of depression compared to stroke survivors without aphasia, and a diagnosis of major depression increases from 11 to 33% across the first 12 months post-onset. Anxiety can also affect up to 42% of stroke survivors with aphasia. So we have high rates of mood problems and a real need for psychological care, but we know from the evidence that there are these evidence practice gaps. So here in Australia, the stroke audit data shows that there are low rates of recommended psychological screening and assessment after stroke. Few stroke survivors are offered counselling, and talk-based psychological therapies are often inaccessible to people with aphasia. So in my research through the PhD, we really wanted to conduct an in-depth exploration to find out more from the perspectives of stroke health professionals and people with aphasia. We conducted 2 qualitative studies, and we used the qualitative methodology of interpretive description to explore and understand perspectives of participants across metropolitan and rural and regional areas of Australia. And we conducted focus groups with a sample of stroke health professionals of medical, nursing and allied health backgrounds across various settings in acute hospitals, inpatient rehabilitation and community services. We also conducted interviews with people with aphasia who varied in severity of aphasia and mood symptoms, and they were at various phases of recovery. We gathered perspectives on current practice, experiences, and the barriers and facilitators to psychological care. Our qualitative study showed that people with aphasia report overwhelmingly negative changes to mood, and here are some of the descriptors they used: imprisoned, terrified, upset, hopeless, overwhelming frustration, excluded, frightened, upset, horrible, really low, and darkness. When we talk to stroke health professionals in the focus groups, we ask them about current practice, and they described trying to support mood, but there are gaps in services and resources. They also reported not routinely screening for mood. Non-speech language pathologists particularly reported limited knowledge about aphasia. They also reported no access or limited psychology services, a lack of confidence to communicate with people with aphasia, negative attitudes to communication disability and psychological health, and that managing mood changes and depression isn't always a priority for stroke care and rehabilitation. So we identified many evidence practice gaps. On one hand, stroke health professionals report that mood difficulties and depression are not always a high stroke rehabilitation priority, and approaches to assessment and treatment for mood problems and depression are ad hoc. On the other hand, in contrast, people with aphasia reported the onset of stroke and aphasia as a traumatic event resulting in mood difficulties and depression, and people with aphasia hold concern for the well-being of family members. Stroke health professionals also report a lack of skills and knowledge to understand aphasia, to also support communication, and to manage mood problems. And consistent with these perspectives, of health professionals, people with aphasia reported unmet needs in their communication and mood problems, and a lack of choice and access to therapy for mood problems. So what are some of the solutions to these gaps in care? Let's talk about that. There are frameworks and guidelines that can help to implement mental and psychological health care for people with aphasia after stroke. And STEPS Psychological Care After Stroke offers a potential solution to overcoming gaps in the service. It's an interdisciplinary framework, usually composed of 4 levels. At level 1, the person with aphasia is screened for possible depression or anxiety, and those with sub-threshold problems in mood stay here for intervention at level 1. Those with possible depression or anxiety are promptly triaged up to either levels 2, 3 or 4 for further assessment and intervention as required, depending on the severity of mood impairment and their needs. Trained speech pathologists and other health professionals can screen for mood problems at level 1 using the clinical tools described on this slide. It's important to find out about any past mental health illness and the person's mental and psychological well-being previously, including their previous coping strategies for past adversity or life challenges. Assessment at levels 2 to 4 require more of a clinical interview with communication supports by a medical practitioner, a mental health specialist and or a psychologist to further assess for mental illness post-stroke. Speech language pathologists can still provide communication support strategies and training to facilitate such clinical assessments with these health professionals. Now let's think about interventions at each of those levels of STEPS psychological care. We conducted a systematic review which has been published in Disability and Rehabilitation. And we asked what are the rehabilitation interventions that can prevent or treat depression in post-stroke aphasia. So our systematic review identified rehabilitation interventions at level 1 for people without clinically significant mood problems. And we found that a range of communication, music and psychologically based therapies may enhance mood for people at this level, and they're listed there on the slide. The strongest research evidence in a randomised control trial showed that behavioural therapy may reduce depressive symptoms compared to usual care for people with aphasia and mild depressive symptoms. And there was also low-level evidence to show that psychosocial group support and problem solving may enhance mood for family members. No evidence was found for rehabilitation interventions at levels 3 and 4 or for any preventative interventions. For people with aphasia and moderate to severe mental illness, mental health specialist care with regular one-to-one psychological therapy and medication management may be effective. And careful consideration of treatments alone or in combination are required due to risks of potentially harmful side effects. Speech language pathologists can play a role in assisting with communication support strategies at these levels with the interdisciplinary team. They can support the person with aphasia to understand the psychological therapies and medication management, and also to optimise communication with health professionals and family members and the person with aphasia. So in this area of practice, it is essential that we work together to address communication and mood problems. As speech language pathologists, we need to co-work with people with aphasia, family members and health professional colleagues. And this is particularly important for managing mental illness and wellbeing in the context of communication disability. So when we conducted our interviews with people with aphasia, we wanted to find out what their goals and preferences would be within a framework of stepped psychological care. And we found that people with aphasia want communication support, they want positivity in their interactions with health professionals and family members, plus positivity towards attaining therapy goals. And they also need a choice and access to tailored therapies to improve their mood and well-being. Family members need support and information about stroke and aphasia and psychological care. They also need communication partner training, and we'll hear more about communication partner training in this IARC segment from Yuda and Murray Kristen. And they also need some skill building, such as problem solving and support and access to stroke and aphasia support groups. Training and co-work is really essential for speech language pathologists. Seek opportunities to upskill through training in psychological care within your scope of practice. And you can find high quality online resources and guidelines from speech pathology professional organisations or associations, local stroke and mental health organisations, conducting joint therapy and assessment sessions with other health professionals such as psychologists, social workers and occupational therapists is also beneficial. And this provides an opportunity for co-facilitating therapies, learning new skills and increasing knowledge and peer support together. We need to continue to find what is acceptable and feasible in terms of delivering aphasia-friendly psychological interventions. And this is what we're working towards in the Aphasia CRE. So let's talk a little bit more about that. I'm leading one of the Beacon projects at the Aphasia CRE, which aims to investigate interventions within level 1 of the STEP psychological care framework. Our research team of psychologists and speech language pathologists will support health professionals at Monash Health in Melbourne to implement the Aphasia PRISM therapy program. PRISM stands for Prevention, Intervention and Support in Mental Health. And the aim is to test the feasibility and the preliminary efficacy of Aphasia PRISM for preventing depression and anxiety and supporting well-being in people with aphasia after stroke. So let's talk a little bit more about Aphasia PRISM. The participant with aphasia will be offered decision-making support to self-select one of 3 psychological therapies. And these are behavioural activation therapy, problem-solving therapy, and relaxation therapy. If we look at these in a bit more detail, behavioural activation therapy draws on the rationale that increasing the frequency of a person's participation in enjoyable activities is rewarding and will improve mood. So this particular therapy aligns well with the LPAA framework. The person with aphasia is supported in a structured way to recognise the link between activity level and mood. And they identify enjoyable activities, plan and schedule enjoyable things into their day, and aim to increase the activities over time. Looking at problem-solving therapy, this is based on the rationale that problem-solving helps a person to look at a situation more objectively to enhance the process of decision-making. So when the person is worried or stressed by a situation, they can change, they can work through steps to solve the problem in a productive way. And the person is enabled to identify problems or worries, to plan and think of solutions or best strategies, and put these actions into their day also. And relaxation therapy has the potential benefit for reducing symptoms of depression and anxiety post-stroke, as shown in stroke research evidence. The person with aphasia practices gentle breathing exercises, muscle relaxation, focused attention to calm the body and mind, and put relaxation exercises into their day. So if we look at a little at the design, we have full ethics approval to conduct a mixed methods feasibility study, and we'll implement the program in the coming months via online telehealth methods due to COVID-19 restrictions here in Melbourne. The first steps will be to train the allied health professionals to deliver the weekly therapy sessions over a 7-week period in community settings. We will investigate the level of acceptability of the therapies to people with aphasia using prospective, concurrent and retrospective acceptability surveys. And we will use psychological, communication and social functioning measures detailed in the second column here in red print to investigate any potential clinical changes. We will also explore the feasibility and acceptability of the program from the perspectives of people with aphasia and the allied health professionals facilitating therapies post-intervention. So to sort of come to the end of my talk, I'd like to thank the participants with aphasia and their family members and the stroke health professional participants who generously shared their perspectives and experiences about mood changes and depression and current practice in this area. I'd also like to thank my PhD supervisors and the Aphasia PRISM research team. And I'd also like to thank the Aphasia CRE, the University of Queensland, and Monash Health and Speech Pathology Australia, who awarded myself a new researcher grant to enable us to investigate Aphasia PRISM program. If you'd like a copy of the slides, or if you'd like to ask me any questions, I'm available via email or on Twitter as well. Thanks very much for your attention, everyone.